clinical trialist and chiropractor, and I was at the University of Western States for 30 some odd years.
Kim Jones, fibromyalgia researcher for the last couple decades, and just for about 3 months ago, I've been the dean at Linfield College.
And I'm Mark Altenhoff, and I'm the staff coordinator for Oregon Pain Management Commission and the Palliative Care and Quality of Life Council.
Hi, I'm Dana Harganani, the Chief Medical Officer for the Oregon Health Authority.
Marielle Smits, I'm the Medical Director for the Health Evidence Review Commission.
Darren Kaufman, Director of the Health Evidence Review Commission.
I'm Nora Stern. I'm a physical therapist and pain educator from Providence Health and Services with about 25 years experience with complex persistent pain, and I'm the chair of the Oregon State Pain Commission.
I'm Laura Acker. I'm a licensed acupuncturist. I've been in practice for 15 years at several different federally qualified health centers, currently at Multnomah County.
I'm Kevin Cuccaro. I'm a physician and pain specialist.
Holly Jo Hodges. Oh, hello. Holly Jo Hodges, family practice physician for 25 years, currently medical director in Salem.
I'm Tracy Moudet, also a family physician by background, former CCO chief medical officer, currently working at OHA.
And I'm Jason Gingrich. I'm a policy analyst for the Health Evidence Review Commission.
And folks on the phone? Where'd the phone go?
This is Jim Shames. Hi, Jim Shames. I'm the health officer for Jackson County, also a consultant for the OHA on things related to pain and opioids.
This is Amber Rose DeLay. I've lived with fibromyalgia for about 15 years, and I'm a public member of the Oregon Pain Commission.
This is Mark Stevens. I'm a healthcare consultant. I've been working with chronic pain and opioids for 15 years, and I'm a consultant to OHA and various chronic pain and opioid-related projects.
Anyone else on the phone? Well, welcome everyone. Thanks for taking some time out of your Wednesday morning. Our first order of business is review of the minutes. When originally posted, the minutes had a quote that was inaccurately ascribed to a person that's been removed. Are there any other changes or errors or anything anyone's noted? And since we're an advisory task force, we actually don't have to vote on our minutes, but if anyone does find any additional things that they're questioning or feel are an error, please let me know.
Ariel, 2 A's, 1 S for my last name.
I am so sorry. We will correct that. It was probably my lovely, spell check or whatever, but my apologies.
No problem.
I'll go back and look at the old minutes. Make sure we have it right. Okay. Great. Well, we were going to get started this morning by having just a brief welcome from Dana Harganani. As she introduced herself, she is the Chief Medical Officer for the Oregon Health Authority. I think she just wanted to give us all a welcome.
Great. Really pleased to be here today with the Chronic Pain Task Force and to meet the members who I have heard about by name, and so glad to be here joining with you today. As you've heard now, I'm the Chief Medical Officer, and in that capacity, I serve, I oversee the Office of Delivery Systems Innovation for the Oregon Health Authority, which includes our HERC staff and team that supports all of the work of the Health Evidence Review Commission, and of course, is hosting this advisory task force. So that's the relationship that I come to at this meeting today. I just wanted to start by sharing a few comments on my perspective on the work and task in front of this advisory committee. and really provide an overview of the intent of the revisions that were made to the proposal that you are all going to be discussing today. I just want to start by reflecting on that we critically appreciate all the public interest that has been given to the work of the Chronic Pain Task Force and the Health Evidence Review Commission. I know that this has been a very important topic for many, and appreciate that. And I just want to say that OHA strongly believes that transparency and public process and input makes our public policy better. And so again, appreciate the strong interest in public input throughout. The Oregon Health Authority's overall mission is to transform healthcare to improve health and well-being of Oregonians. So at the heart of this work that the task force is considering is to expand access to evidence-based therapies and treatment options for patients with 5 specific chronic pain conditions that are currently not covered or funded in the Oregon Health Plan as it stands today. So we are truly looking to expand access to services. This benefit package really, again, at the heart of it has really been focused on a menu of non-pharmacological pain treatments and services that are currently unavailable. The task force, as you all have been working hard on, has put together a benefit package proposal that includes a breadth of options. In addition to the non-pharmacological treatment options that you all have been discussing a lot, of course, the task force and the Health Evidence Review Commission staff have had to consider additionally what pharmacological treatments should be covered if these conditions were to be covered under the Oregon Health Plan. How do we make those available, and what is safe and effective? So we do know that the vast majority of public input has been focused on the topic of opioids, and appreciate that. We really wanted to make sure over the course of time since August, when the original proposal was presented to the subcommittee of the HERC, that we take steps to ensure that we are listening to the public input, we are listening to the expert input that has been given to make sure that we can consider all of that in the revised proposals, and to make sure the task force and the HERC staff has all the resources and information it needs to make considerations. So I just wanted to outline for task members, again, what we've done in the interim to really consider the resources and information available. So first, we did amend the makeup of the Chronic Pain Task Force to add expertise around chronic pain, and particularly as well individuals with experience and expertise in substance use disorder. So that occurred over the recent past. We have solicited expert testimony, some of which you heard at the last meeting, and certainly we've received additional expert testimony through public comment. We requested and updated the evidence review on opioid tapering from OHSU Center for Evidence-Based Policy, which you will be, hopefully have looked at and will be discussing today, and also requested and received input from our coordinated care organizations, again, which you have in your materials and will be reflecting on today. So we as staff have truly been listening to all the public input, expert testimony, looking at the new evidence review and the survey feedback from CCOs, which is reflected in the revised proposal that we have shared with you for your discussion and advisory discussion on today. At the heart of the revised changes, we wanted to make sure it was clear that we, OHA, believes that healthcare delivery is really dependent on the trusting relationship between a patient and provider. And that as we have reworked the proposal, that has been paramount and at the top of our minds as we've created the revisions. All of the proposal elements, particularly addressing opioid tapers, which again has been at the heart of a lot of public comment, really all of it, including the timelines, the rates, and the ultimate success of getting to zero, are intended to be flexible and to meet individual patient needs based on that patient-doctor relationship. So I wanted to again take a couple minutes to outline the changes that we put intentionally into the revised proposal that you will be discussing to really outline that with reflecting this intent that I just mentioned as you kind of to frame your conversation today as you move forward. So a couple of the changes. First, recognizing that long-term opioids can be appropriate treatment for some patients. This revised proposal allows for safe and appropriate prescribing for these patients without a taper plan. So we hope that you've noted that in the revised proposal. For some chronic pain conditions, opioids have been found to be ineffective and unsafe, and therefore a taper plan is appropriate. This new proposal specifically recognizes that tapering is an individualized process, again, with shared goals between patients and providers. And for these patients, the proposal recommends a taper plan with a goal to 0, but we understand that at a specific time frame or success of getting to 0 will be flexible based on the needs of the individual patient. Additionally, based on expert and patient feedback, we emphasize the expectation that the taper plan should be individualized, particularly with regards to the timeline. The proposal does reference a suggested taper rate of 5 to 10%, which was informed through public expert input. This is intended to be a goalpost and to help providers engage with their patients on the discussion of tapers. Again, it's intended to be flexible and individualized. And I think based on the public input that has been received to the task force in the interim since these revised proposals have been put out, I would suggest that this would be a discussion for a topic today. You know, is the idea of a goalpost for conversation reflected in that still representative of the intent of it being individualized? And is there any language that's needed to be changed? Some final additions that have been made to the revised proposal. One, it now includes language to recognize that medication-assisted treatment and other treatments for substance use disorder are covered by the Oregon Health Plan, and that is the intent that it continues, and so wanted to make sure that was clear with regards to this topic. And then also with regards to changes in language to the revised position on tapering, we will ultimately ask HERC, you know, dependent on this discussion and as revisions are made any further, to align the language around tapering in the back pain guidelines as this moves forward to the HERC. So again, I just want to, in closing, acknowledge the really important public process and the strong interest and input from everyone in, that has really taken us into the current discussion today. I do want to encourage the task force, as you're reviewing and discussing the revised proposal today, to consider if the intent I outlined, really that individualized approach, is really represented in the language, as has been questioned in some of the public comment that you've received. I also just want to acknowledge and encourage people to remember today is a working task force meeting. So this is the task force discussing and considering the revisions and discussing any recommended changes that they might advise to the health authority. Public comment continues to be really important to us. We do have public comment scheduled for half an hour from 11 to 11:30, and that will take place before the final discussion and decisions are made by this task force. So I appreciate everybody's advanced efforts for a professional, productive conversation today as a group. And again, glad to be here to participate that and listen to all of the input that this advisory committee has for us. And then I'm going to pass it, one of the task force members, Nora Stern, also wanted to share some of her reflections from the positions that she sits in for the task force before we then dive into the conversation. So Nora.
Thank you. Thank you. Can everybody hear me? This on? So I am the chair of the State Pain Commission, and as part of membership on this task force and also as part of the commission, we've all been very aware of how much challenge there's been in the community around the guidelines that are being considered here, especially around opioid prescribing. So I wanted to get a chance to kind of frame things. I think we all are participating in this task force as volunteers and as staff members of HERC because we're deeply concerned about bringing better pain care to the residents of the state of Oregon. And I want to appreciate people's contribution to helping create better pain care for Medicaid. And to kind of give some context for how we got here. In healthcare, you know, we got pain care so wrong for so long, for 400 years. We, as clinicians, and I think as a community, misunderstood pain. We thought that pain could only be explained by what was happening in the body. So if you couldn't cut it out or numb it or take an x-ray of it, that pain was somehow less real and a person's pain experience could be dismissed. And that led to lack of coverage for the kinds of treatments that actually could be effective. And to a clinician, maybe not understanding the options that were available and also only being able to offer a person opioids. And so that led to a situation where patients maybe were in a state of maybe feeling scared and hopeless and dismissed. So this process is really about changing that. I think that we're at an opportunity in Oregon to even give some examples to the nation of better ways of treating pain and changing the way that we spread healthcare dollars around, and it's a tremendous opportunity. These guidelines I'm hoping, align more closely with what we now understand about pain, that pain is a complex experience, that it includes information that comes in from the body. It also includes the way that the brain processes information, how much sleep you get, what food you're eating, the activity that you're doing or not doing, your senses of fear, distress, and hopelessness that might be going on, or your sense of hope about pain. And that each of those pieces of the puzzle also represent opportunities for treatment. And that's what we're able to do today, is look at the evidence for treatment that addresses those different pieces of the puzzle. So I think that what we're looking at is a chance to really provide services that were not previously available, and really hopefully get to a place where we have a different landscape for treating pain than we ever had before. So at the same time, we have a situation where people have maybe not gotten adequate treatment for years and have been primarily offered the treatment of opioids, and so the idea of that changing can be pretty scary. I hope that we'll get to a place in the future where we have a lot of other services that are offered, so that we don't have this really challenging situation of feeling like there's only one way to treat, and that isn't working very well. I think this task force has struggled with and heard the words of the community and the concern, and recognized the place we're at right now of being in this state of transition where clinicians are learning more about how to treat pain better. I think the Pain Commission has helped with that, with some of the pain education that we've been providing, as have the different professional training organizations and institutions as well. So we're in this difficult, challenging period, and so I think the task force has heard loud and clear from the community, from researchers, from clinicians, what the state of things are and what the challenges are. And I want to applaud the task force for hearing those things, for integrating those comments, for looking back and asking for more input from OHSU, from integrating public comments. So these are unusual times, and I think recognizing that is reflected by the fact that we've had more public comment period than any other task force, I think, ever has, and that has helped enrich the discourse that we've been able to have. So thank you again to the task force, to the community, and to the members of HERC staff as well for being able to bring us to what will, I think, be a really wonderful change for people who struggle with pain and who get Medicaid services, and set an example, hopefully, for other insurers in the future. Thank you.
Thank you, Dana and Nora. Thank you. So I just wanted to kind of run through what our tasks are today. First, I'm just going to do just a brief overview. I know you all have been very immersed in this work, but just kind of give just a brief update of where we were up to now. Just do the attention. That's the next one. And then we'll review the information that you all requested. So we have sort of a summary in your packet. You've got a much longer summary, and we have sort of a brief summary in the meeting materials of the CCO survey, and then the highlights from the Center for Evidence-Based Policy opioid taper review that we requested. And so we'll go through those, and then we will review the proposed sort of suggested changes that staff have worked on to the proposal that you all brought to the HERC in August, and just kind of run through step by step what those changes are and have some discussion. From 11 to 11:30, we'll have time for public testimony. And then when that wraps up at 11:30, we can take all of that into consideration, and you all can kind of give staff your final directions, sort of where you think any corrections or any clarifications or anything that you feel need to be done. And then we will come up with some next steps and adjourn. So hopefully that is a reasonable strategy for all. Okay. So just to kind of remind us all, we've been on the kind of a path for a little over a year now, and you've all come to multiple meetings. We started out by doing pretty in-depth review of what types of therapies are effective for chronic pain, and kind of landed on a package of things like cognitive behavioral therapy, physical therapy, exercise, acupuncture, and then did a brief review of medications. One of the other things in your packet is a more detailed review of some of the medications that we asked the Pharmacy and Therapeutics Committee to do. We came up with what we thought was a near final proposal in June at our meeting, and that was reviewed by the Value-Based Benefits Subcommittee of the HRC in August. And then we heard a lot of public testimony. We had another meeting at the end of September, which was basically a listening session to really hear from experts and the public about what they felt about the proposal and their concerns and their input. Staff and OHA leadership and staff and folks have really kind of buckled down and looked at all of that input and come up with this sort of revised proposal that we'll give you all. So, diving in, the first piece of information that you all requested was the survey from the CCOs. So for the members of the public who may not be familiar with all of our acronyms, CCO is Coordinated Care Organization. So Medicaid in Oregon is mostly delivered by these organizations that are local. They're meant to be local. They're meant to respond to sort of the local resources and community needs. And there are 15 CCOs. They provide about 90% of the Medicaid care, and then the other 10% are open card Medicaid cases that come through the OHA sort of main group. So the CCOs do most of the frontline care. We asked them about the backline changes. So if you all recall, back in 2016, we made a pretty dramatic change to how we took care of back pain. Prior to that, there wasn't a lot of services available to folks. And we moved uncomplicated back pain above the funding line and added a whole package of services. The CCOs have basically reported that they've been implementing, the vast majority have implemented most or all. There is a few issues that are kind of being worked through about some access to certain types of specialty care, and some continuing issues about just not having enough availability, et cetera, but that they really felt that they were either successfully implementing or in the process of implementing all of these types of services. There was concerns for cost. They found that these additional services were a net cost. I think we all feel that in the long run, the big picture, they may be cost savings, but in the short term, they have been at an increased cost. And then we asked them about the new proposal. We sort of universally concerned about some of the increased costs, particularly for the non-pharmacological services. So increasing access to PT, cognitive behavioral therapy, acupuncture. They were concerned about the cost and also the fact that there's already a bit of a struggle in their communities for some of these services. And so widening that would sort of put a little bit more of a strain on them. The CCOs were mixed on whether they felt that coverage for chronic pain would improve the health of their patients or simplify any administration issues. And they were all uniformly interested in trying to align with other statewide efforts, statewide guidelines and things where they deal with acute and chronic opioids. Any questions about the CCO survey? In your materials, there was much more detailed information about specifics and percents and things like that. But the take-home point is I think that they're really trying. They're working hard to implement additional resources for folks with the back pain, and that they're aware of what we're doing with chronic pain. They have some concerns for cost, and I think OHA is cognizant of that, and this would be a biennial review change, meaning that this would have to go through the legislature to request additional funding, and that would hopefully address some of those cost issues. Any other questions or any concerns about the CCO survey? And then we asked the Center for Evidence-Based Policy to do an evidence-based review on opioid tapering. Overall, they felt that the quality of the evidence was low. Essentially, there's very little evidence for many of the questions we were asking them. They had done a previous review a couple of years ago, so this was actually an update and an expansion, asking some additional questions from their previous review. They did not find any studies that changed their previous conclusions, which were that pain, function, and quality of life might improve during and after opioid discontinuation or dose reduction. They found scant evidence of harm in general, looking at the literature, because of public concerns over harms. We asked them to really parse through their studies on those. They found 5 studies that included adverse events. There was only 1 death reported, and that was a patient who was on buprenorphine after buprenorphine was discontinued. Kind of an unclear what had happened there. But overall, in all of the literature that they could discover that included adverse events, there was the 1 reported death. They also found 1 study that looked at suicidal ideation and self-directed violence. This was a study that is not really directly related to the population that we're considering. This group was had clinician discontinued opioids because of aberrant behaviors like diversion or using other illicit substances, things where I think best practices in any medical situation would say that these folks needed to be off. Also, these folks had a high rate of underlying mental health issues going on. And they found a rate of about 12% had suicidal ideation and non-fatal suicidal, not self-directed violence in the 12 months after opioid discontinuation. Other than that one study, they didn't find any that reported on suicidality, overdoses, mortality, etc. They did find that opioid withdrawal symptoms were reported. The rates varied from 0 to 100%. So, not surprisingly, as you're taking away a medication that you can develop physiologic tolerance to, there is some level of withdrawal. But then, and the new studies didn't provide any additional information on that. They found no evidence that could draw any conclusions about tapering length. We specifically asked them to look at patient-initiated versus non-patient-initiated tapering, feeling that these might be 2 significantly different populations. They weren't able to really parse this out, looking through the literature that they could identify. They did find 1 VA database study that had both patient-initiated and clinician-initiated discontinuations, and they found no correlation in pain score trajectory based on the type of, the reason for discontinuation. There was 1 study that looked at clinician-initiated discontinuation, and the vast majority of these were due to aberrant behavior like abnormal urine drug tests, opioid diversion, etc. And they found, again, sort of a highish rate of suicidal ideation, etc. And again, this was a group that had reasonably high underlying mental health disorders and had previous suicidal ideation prior to their tapers. And then there was 1 new study that compared mandatory opioid dose reduction in a healthcare system to usual care. This was randomized by clinic, not by patient. And they found no indication that patients in the intervention clinics had clinically meaningful differences in pain intensity, interference with activities or enjoyment of life, or depression symptoms compared to the control clinic patients. You all got the complete report in your packets if you want to look at all of that information. Any questions or any specifics that you want pulled out of that report? Or
Just a clarification on what is meant here by scant evidence of harm. Is it because there's very little evidence?
There's very little evidence.
Do we have a very low end here? Is that what we're talking about? Or just a
many
low
of the studies didn't report harms, whether that meant that no harms happened or they just weren't reported. It wasn't able to be distinguished. So they were looking at a small number of studies, so then a smaller number of patients that actually systematically had followed and tracked harms.
Okay, and also when they say a very low level of evidence, are we talking about very small randomized trials, pilot-sized studies? Or?
Many of them, if they were, so there was no crystal clear randomized controlled trial like we would expect in the medical, like a drug study. The last study I talked about in the Washington State study, they randomized by clinic. It's not ideal, but it was the one sort of a way of randomizing. It was sort of a pragmatic randomization. Many of them were looking at like the VA data. A lot of it is their electronic medical record. So there's sort of retrospective looking at these were the patients who were tapered, why were they tapered, what happened to them. The VA has a very robust way of looking at that data. There is one study in here that the VA did prospectively where they were looking at tapering. And it was a mix of patient-initiated and provider-initiated. So yeah, so it's a heterogeneous literature where there's many different ways of looking at the question, not a lot of sort of crystal clear randomization, that kind of thing. A lot more cohort studies, pragmatic randomization, that kind of thing. So when you look at how like the evidence, the Center for Evidence-Based Policy, how they use like the grade GRADE, the all capital, that kind of grading system. So a lot of these don't meet the highest rank of that because they're not a crystal clear. This group of completely equivalent patients to this group were randomized to these two different strategies.
Okay, that's good to know because, often with the grade system, if it's not a randomized trial, it starts pretty much low.
Right.
With little chance of moving up.
Exactly.
Okay.
Yeah.
Thank you.
Yeah. So it's not that it's bad literature, it just doesn't meet the highest quality of evidence. Is that clear to everyone?
Yeah. I think it's important to realize, though, that that is the quality of most pain literature out there.
Exactly.
So when you're looking at anything in pain, most of it is pretty low quality.
That's a very good point, and they make that point in the review that even the meta-analyses and the things they're looking at underlying studies that are not ideally created.
Well, even the things that we're doing that are widely out there
Right.
and being performed have low quality evidence.
Many epidural steroid injections.
Right.
We won't go there. But yes, you're right. Many different interventions are poorly studied or not studied. Someone on the phone have a comment or question?
That was my dog. I had unmuted. Sorry about that.
No problems.
Are you accepting comments from public members?
Our public comment session will be from
Okay, I
11 to
understand.
11:30.
Okay, so you were asking members of the
Yes.
team? Okay.
Yes. All right. Ready to move on? Okay. And the one last thing that we had brought up briefly at our last session was that there was a previous fibromyalgia guideline that wasn't included in all of our work that we did last year. And this was created in 2008 and 2013. Fibromyalgia has been brought up several times for review for coverage in the past. And so the evidence was reviewed specifically for that. The guideline that was developed, it was for an uncovered condition, so it never really was, widely kind of used. But it basically mirrors our current proposal, and there was an additional sentence in there that the use of opioids should be avoided due to evidence of harm for this condition, which theoretically was moot because that was an unfunded condition, so it shouldn't have been getting medications paid for. But we know that that's not how things happen in real life are not exactly how the ideal policy situation. We asked the Pharmacy and Therapeutics Committee of the OHA to do a review of medication specifically for fibromyalgia, and they found some evidence for benefit for specifically Lyrica, a little bit for gabapentin, not as much for Cymbalta. They looked specifically at tramadol, which is a opioid that has some other effects, and they found no evidence of benefit. Again, we're getting into the area of poor studies where some of the lack of evidence may just be the lack of underlying research, but their conclusions were that it doesn't appear to be effective. So that was just one additional piece of information that you all just needed before you kind of jump into what we're all going to discuss now. Of course.
Yeah, so this is Kim Jones. I'm not clear about how they came to that conclusion regarding tramadol. There are 3 RCTs, placebo versus tramadol with or without acetaminophen, specifically in fibromyalgia, and there were statistically significant and clinically significant differences between the groups in favor of tramadol. And then there was one meta-analysis, and then tramadol's been listed as in various statements from various countries about ranking treatments for fibromyalgia. In the Germany and Israel and the Canada guidelines, it was ranked at the top. Now, more recently, because that happened all before Pfizer and Lilly and Cymbalta and Lyrica and those sort of things. So as those have had more evidence, enough to get through the FDA, then tramadol has sort of moved down the line a little bit in the literature. So I'm just not clear how they came to that conclusion specifically regarding tramadol.
If you can provide us with the citations for those studies, we can go back to the center and find out if they didn't meet inclusion criteria for some reason.
Okay. Yeah, because the history is Ortho Pharmaceuticals was going to take that to be the first FDA agent, and then so the studies were exclusively in fibromyalgia. But as it came closer to time to go to FDA, they decided for sort of a different request for an indication that did not specifically say fibromyalgia, because that had not gone through in the past. So they were not clear about what were the goalposts, what were the required endpoints by the FDA.
Yeah, so if you just want to send me,
yeah,
or you can do her
they're
info
old
either way.
studies.
But if you send them to me, I
Okay.
can talk to the PNT staff that did the review and see if they were included, and if not.
Okay, thanks.
And so one thing you said there, they were old studies, that could be possibly.
Yeah, that might be it. They were in the 2000s, but not in the last decade.
As a general rule, I don't believe PNT goes back beyond 10 years with just a general review, but I could be wrong. I will check with their staff. And
so if that's true, if the studies were just too old, I'm not sure that would be finding no evidence. It would be finding no evidence in a certain time frame, and we certainly use old drugs like Neurontin, for aspirin, exactly. Despite the evidence base being more than 10 years old.
Yeah, so it's just either send HERC info or send it to me, and we'll work with the PNT.
Thanks.
And this is Amber Rose. As a public member and somebody who actually was in the 2000s and was a patient of Kim's, the tramadol was the turning point for me personally to be able to do the other thing, which is exercise. And so I think that as we're looking at the evidence, I know we're looking from a policy standpoint, but when we bring it into practice, I think it's really important to give the practitioners and the patients the tools that will be able to get to the end point. Where people are able to manage their pain. And so sometimes something like tramadol in terms of fibromyalgia can be really helpful even though it hasn't been studied. So just want to throw that out.
So one more comment, just memory of the past. Tramadol was out for several years before it was scheduled. So it wasn't a scheduled substance until it had been on the market for quite some time. And, it has some SNRI activity with some affinity for the mu-opioid receptors. So I think it appropriately got scheduled, but it's a lower schedule.
Any other comments? Are you all ready to dive into the sort of nitty-gritty details? Okay. So, you all have a much more readable copy probably in your files. But if you don't, there's slides back here, and it's unfortunately the guideline got broken into like 8 slides so that it's still readable. The very first, and then Darren deletes it all. So
Does this randomly?
the first section of the proposal is about the line itself. There's essentially no changes here from what you all saw in June. So it continues to have the 5 ICD-10 codes that you all had picked out. The CPT codes are all the therapies that we reviewed in detail, like CBT, physical therapy, acupuncture, office visits, etc. And the HCPCS codes are kind of our usual substance abuse screening, some FQHC codes, etc. Any concerns about the actual diagnoses, any additional diagnoses you would want considered, or any one you want taken away, any other coding kind of concerns?
So for the prolonged office visit, do we know how long that visit time is, the time allotment?
I think it's in the code. So the words here will not be in the final list description of the line. It's just whatever that's sort of the standard that we put on office visit lines. And most people, I think, actually just upbill frequently. If they're having a prolonged visit, they'll bill a level 5 or something based on time. Okay. Holly Jo, you had a look.
It's not up billing, it's appropriate billing.
Thank you.
You'd be using.
Thank you. Although apparently CMS is moving forward with making us do more appropriate billing. Okay. So then the next portion is the guideline. The first section, you'll notice a change from what you saw in June, and that's where we spell out in words all of the diagnoses that we're discussing. So I think we all kind of understood, based on prioritized list, if it refers to a line, it's only the diagnoses on that line. But it's, I think, difficult for the public to kind of understand our intents there. We heard a lot of concern from public and providers that we were going to include other, like cancer or like children with, serious metabolic disorder, those types of things. So we wanted to make it crystal clear that these are the only diagnoses that are appropriately in this guideline. Does anyone have an objection to spelling all of that out in great detail?
This is in reference to the previous slide. Can somebody help me understand how the previous person, can you go back to the previous one? How those codes relate to group visits for different disciplines? I'm thinking of that physical therapy, for example, is very poorly reimbursed for group visits generally, to the extent that it's discouraged, and yet group care is often better practice for complex pain.
So we have a standard set of codes that we use for physical therapy that are just kind of carried over on every line. I'm not sure if group therapy is included. I can look. I know that in the psychotherapy there is a code for
Right,
group
psychotherapy
therapy.
is better covered.
Yeah, I know there's a general problem. I mean, there's group visits for like diabetes or OB care, those types of things, and I don't know if those are appropriately I don't even know if there's a code for them. I know that there's some difficulty getting those reimbursed.
So this is a contracting issue and not something we can impact in this group.
Okay. Okay, thank you.
Yeah, so I know that there have been some efforts to do that, and I'm not sure how they all get it paid and all, but your local CCO might work with you if you want to come up with like an innovative group kind of strategy or something. Going back to the guideline, so we had that first new paragraph where we just spell out to kind of make it clear to the lay person reading what we're talking about. And then the treatments, which are kind of following in this and the next slide, we didn't make any real changes there. So these are all the things that you all had previously wanted in the guidelines, so pain education, cognitive behavioral therapy. I know we had a long discussion about including acceptance and commitment therapy, but the feedback that we got from the mental health division at OHA was that that's considered a subset of CBT, and they didn't want it called out. They wanted it just included under CBT. So that's the intent is that we would cover anything that is like that type of CBT therapy. And then we have also, if it's available, the yoga. We changed it based on hearing from you all that it's going to be adaptive and restorative yoga rather than just generalized yoga. It may not be, if a CCO is using punch cards or something, we may not be able to know what type of yoga they're doing, but that's our intent. Exercise therapy, interdisciplinary rehab, etc. And then there is a total of 30 visits when medically appropriate for physical occupational therapy and acupuncture, so 30 visits of some type of combination, and this is tied to the back conditions guidelines, so those 30 visits will be shared between the back line and this line. Mainly because it was sort of an equity issue. If you have back pain and you have fibromyalgia, you get more visits than if you just had one or the other, and so it's a shared group. Any questions up to this point?
I'm just going to make a picky comment.
Mm-hmm. No, picky comments are great.
We need to make the guideline in outline format with numbers and letters and so on. It just makes it a lot easier to implement at the plan level when you have a reviewer who's looking at the points. It just makes it easier to point out subsections of the guideline.
Talking about the yoga portion, I think that criterion about restorative yoga is a good one. I thought we were also going to bring in Tai Chi. And I would actually say there's a movement among people who are doing, there's a movement among movement therapists to couch intervention under the rubric of mindful movement, which could be yoga, it could be Tai Chi, it could be something that, it could be Feldenkrais, it could be a kind of a hybrid of movement experiences that help people develop more kinesthetic awareness, and that kinesthetic awareness and ability to understand and feel safe moving is the most important thing. So I thought there was also some, I think there's pretty good evidence about Tai Chi for fibromyalgia as well. But I would say rather than, I would prefer that it say mindful movement, including Tai Chi, restorative and therapeutic yoga, Feldenkrais, and other related techniques or something like that. You agree, Kim?
Yeah, it's, the Tai Chi study was in New England Journal of Medicine. NIH has a whole page on their website about mindful movement and fibromyalgia, and quotes some our yoga studies and Tai Chi. I don't remember Feldenkrais being on there, but
no, I don't think it is. But I think that if we think about the spirit and intent of the work, I would hope that we would be able to accept that as. I mean, I don't think there's that many community-based Feldenkrais sessions available
right.
anyway.
And it's not that it's a negative study. I just think it doesn't exist.
Yeah, they are not well supported for research. Yeah.
And I do recall running across Tai Chi mentioned in various guidelines. I will take a look at that and see if there's, and see if pull up what information that we have. And does anyone object to looking at Tai Chi?
It would muddy the waters immensely from an operational standpoint. At a clinical level, that would, without, again, we get back to that, which we've dealt with now for years, without a specific CPT code for each one of those different modalities, it makes it very difficult in our current system to operationalize anything like that.
Is this something that is covered with the CPT code? Because I thought that yoga was not typically, that it was just an extra service that's encouraged.
We found a CPT code that was really vague-ish, exercise-ish, and we put it on there, and then that caused some problems because then...
Yeah, these aren't clinicians typically.
And again, reaching for the moon sometimes takes several journeys.
Okay. What would be your recommendation?
Don't muddy the waters.
And just keep it to yoga only?
Yoga alone will be a challenge. Just from an operational standpoint.
Uh-huh.
And again, it's our system,
Uh-huh.
the whole healthcare system, based unfortunately on very specific codes. But when you get down to individualized PA requests, it would be incredibly difficult.
So we have S9451 on the guideline. Are you
Helpful to have on the guideline? I don't know if my microphone is on, but.
It's on.
Okay, so I think that's helpful to have in the guideline. I think that what Holly Jo is expressing and what I would agree with is that it's sometimes difficult to call out in a medical benefit things that are not medical services. And while we can certainly educate and share, and the CCOs have the capacity to develop community programs that include activities that have some evidence of effectiveness, when we put them on the prioritized list in the guidelines specifically as Tai Chi, it becomes difficult to implement. And one of the things that we talked about, especially early in the task force, is one of the benefits of activities like yoga and Tai Chi are kind of the de-medicalization of the pain and the social aspects and so forth. So I think that I would agree. I think let's not call it out specifically in the guideline. I think we can share information about what is shown to be effective or not, but I wouldn't put it on the line. Keep the exercise code because that can be applied to a lot of activities for which we want to track and potentially be able to pay, but I wouldn't necessarily call out those specific exercise therapies in the guideline further than what we have. Does that make sense?
And we do talk about supervised exercise, which you could consider Tai Chi as being.
I agree. Yep.
So I'm just a little confused about when we go say exercise, how does that intersect with the mindfulness, which may or may not necessarily be exercise? Is that included? I'm just sorry, I've just got a little lost.
We included mindfulness training, which might be exercise, it might be meditation, it might be cognitive behavioral therapy. It could be
Okay, great, thank you.
Any other thoughts or comments on the?
Yeah, so it's just a shame to think about, encouraging people to exercise, whether it's mindful movement or some other form of exercise is probably the most effective tool available for chronic pain. Is there no way, I know we don't want to medicalize it, I know that, if you're paying a healthcare professional to teach these things, it becomes much more expensive than if someone's going to the gym or whatever, but is there no Silver Sneakers program? Is there no way to continue to express this intent or fund this without muddying the waters by way of the prioritized list in this guideline? Does that make sense? Do you understand?
We could do a multi-sector intervention statement.
Yeah. So what Jason was talking about is we also do what we call multi-sector interventions. These are things that aren't medical. So they might include putting sidewalks in your community so that you have a safe way to walk, those types of things. So we could put this on the list of things to consider for, yeah.
So what would that look like for this realm of mindful movement and encourage a safe and return to activity? What would that look like to the patient and the clinician who's making the recommendation?
So these have been, we've only done a few of these for tobacco and pregnancy and obesity, and they're all different. And so we would need to look at the literature base. Basically, it would be saying, it would be taking the available literature, which may not be of the same kind that we use for, like a drug trial, It may be observational or narrative literature, and making a statement that the commission feels is evidence-based about these sorts of programs. And it's part of the list PDF document. It's available with the list, but it is stated clearly that there's no mandate that the health plans provide quote-unquote coverage for these services, but they might use them, for example, as multi-sector interventions or work them into some value-based payment arrangement or primary care home or that kind of thing.
Yeah, it's basically a review of best evidence for things, and there's things we can't pay for, like there's things like lobbying for higher tobacco taxes was one of them. I mean, there's things, it's all great ideas, but not necessarily anything that we can pay for. So we could do that. So if we do any changes to the prioritized list, nothing is going to happen until 2020. So that would give us time to do a multi-sector intervention that could kind of be a companion piece to this, if we want to look into that. Yeah. Yes.
I mean, it's
would-
fairly global, but I'm imagining something along the lines of a Silver Sneakers program or something like that, for Medicaid.
Yeah, so I feel like those are great things to address in like a multi-sector intervention report, and what organizations can do with that evidence is use it in things like a community health improvement plan. That way, if they're going to develop community programs, they're developing programs that have some degree of evidence.
I strongly support this move, and I mean, I can tell you, having just recently gone through the experience of hiring a yoga mindful movement instructor to do more restorative mindful movement, that the landscape is such that the people who are doing the kind of glamour yoga in gyms are bringing in more than $100 an hour, and the people who are working with people with complex pain are getting far less than that. So there's a disincentive to serve this population, and it should be the opposite, really, if we want to meet healthcare needs. So I really strongly support this direction.
So what I propose we do is we suggest, when we bring this report to the HERC, that we suggest that one of the things you're asking for is that we consider doing a multi-sector intervention
Absolutely.
review. Obviously, the HERC has to approve whether they want to spend resources in that way and kind of prioritize it. But I think that might be a good recommendation from this group.
Absolutely.
Does anyone object to that? Does anyone feel that that's not appropriate? All right. So obviously we won't have any input on what that's going to say. That it's going to take a while for that to come, but we'll request that they consider doing that. All right. Are we ready to move on to the next part of the guideline? So this portion of the guideline concerns non-opioid medications. So this is pretty much what you all approved back in June. They need to be FDA approved or supported by compendia. They have to be prescribed with some sort of an active therapy or continuing maintenance of self-management strategies. And they need to be reassessed every 90 days. And there should be, I think what you saw in June was it was continual improvement. We realized this would get above 100% at some point. So there needs to be some initial improvement and then maintenance of that improvement. And then once these medications have been established as being very effective for somebody, that you could space out the need for review. Anyone have any concerns there? Okay. So
Can I ask a couple questions? Sorry.
Sure, of course.
So our pharmacist, Lisa, is calling out compendia appropriate and or relevant? I guess I'm a little worried that not everybody may have access to that, or is
That's what the Pharmacy and Therapeutics Committee told us is their standard.
Does that make sense to you, Lisa?
Yes, it does in a theoretical, but again, like you said, in the practicality of reviewing these for, that we don't always have that information available to us.
I mean, I'm just worried that that's something you have to purchase or have access to on an everyday basis, and I don't know that that's realistic. And so I don't know if we need to change that wording to usual standard of care, evidence-based.
I think that language comes from federal drug rebate law.
So.
I'm just worried that that's not going to be practical.
Yeah, I mean, I don't know, it's not necessarily taking place in the office with the patient that they're
Right, but even at your level,
standardized.
do you have access to it?
No.
So we had initially said FDA approved, and then we were told by PNT that we had to expand it to compendia because there are some things that predate the FDA or have other, so that's what the compendia is.
Okay, well, it's distressing that I don't have access to that, and neither does the people working in this field every day. And then my second question was, where did the documented evidence of initial improvement of function of at least 15% come to? Where did that 15% come from? Where's the evidence that supports that number? I'm sorry.
Yeah, I don't think that we had a specific, I think we had just decided on a.
You know, actually, Ariel presented some evidence based on some of the standardized tools that said that about 10 to 15% could be considered clinically relevant. Because at first we were talking about measurable.
Right.
And, you know, you can measure a very small change that's not clinically relevant, and that was the recommended threshold for a clinically relevant improvement. Am I right?
Right, that's right. And that's what we've been using as the threshold for clinically meaningful in coverage guidances that we've been reviewing that deal with pain and function issues.
I thought that number had been 30%. Okay, sorry, thank you.
And to address your question, Holly Jo, if they're, going back to the compendia, if we put that in there and it becomes problematic for the CCOs, we can always readdress and.
I'm telling you now, it's problematic.
I don't know. So I respectfully disagree with my colleague here. I think that if it aligns with the language that the P&T committee uses, which is what we originally talked about, I think it's worthwhile. Because we recognize, like you said, there are a lot of medications that have sound evidence base, but not an FDA indication. We have some that have an FDA indication with no sound evidence base, but that's a different question.
Okay. Moving on. So the next section is probably where the vast majority of all the changes went in. And this is where we talk about our opioid guidelines. So we start out, there was a lot of discussion in this group and also within OHA staff about the difference between centralized pain syndrome and other types of pain syndrome. There's not a definition that's clearly accepted for centralized pain syndrome. There's no specific ICD-10 code for centralized pain syndrome. We know that fibromyalgia responds, the evidence for opioids is that it's not very effective, and there's many experts who've given us feedback that they're harmful for fibromyalgia. There's other centralized pain syndromes. They may be coded as chronic pain syndrome. So that would be a frequent code, although that could represent non-centralized pain syndromes. It's just a lack of our ICD-10 coding. So these are opioids for chronic pain syndromes when they are not centralized. And that the opioids for 90 days will be covered if they are in alignment with the Oregon Chronic Opioid Prescribing Guideline. And we gave you a link you could access and look at that full document. And then the other portions of this are sort of standard wording in like the CDC guidelines and other statewide guidelines, other payer guidelines, a lot of the sort of expert tools, et cetera. And so you need to do a risk assessment, you need to check the PDMP, you shouldn't be co-prescribing with benzodiazepines, you need to check a UDS. They should not be using illicit drugs or have an active substance use disorder outside of tobacco. Ideally, their MED should be below 50 or between 50 and 90 in exceptional circumstances. If they are above 50 MED, which is morphine equivalent daily dose, Every attempt should be made to taper them down according to taper guidelines. They should have an initial improvement of at least 30% and then maintain function throughout the prescribing period. You should address any comorbid mental health conditions. No additional opioids to be prescribed for flares, although if there's acute injuries, surgeries, et cetera, then appropriate prescribing, if clinically appropriate. The prescribers should have updated opioid prescribing CME and ideally completed the Oregon Pain Management Commission module on pain. The patient and provider have done the material risk notice from the Oregon Medical Board regarding the risks and benefits of therapy. And the patient should be prescribed some type of patient pain education, ideally the Pain Management Commission's module when it becomes available. So this is sort of the world that we're outlining for those folks who have non-centralized chronic pain. Thoughts, concerns?
Maybe this is where Holly Jo was recalling something about 30%. So we've got 30% as the initial improvement here, and 15 above was, can you talk about if that was?
I believe that was because that's what we did in the back opioid guideline.
Can you flip back to the first page for a second?
Yeah. I can't recall at the tip of my tongue why we chose 30%.
Can you speak into that?
Sorry. So we're just talking about that difference between the 15 and 30%. And Dr. Cuccaro is also recalling that 30% is perhaps a more appropriate target, and maybe we should align those numbers.
Wasn't that
clinically
non-opioid
meaningful
versus opioid? Is it not the difference? That was for non-opioid
It was
guidelines.
15% for the non-opioids and
But should they be the same?
I think some of that came from where at the threshold at which the benefit outweighs the harm, I think is what, if I recall from the back pain guide.
This is Jim Shames. It could also relate to David Taubman's work where he talks about the overall benefit of opioids, and he puts it at about 30%.
I think it's just important to recognize that difference, though, and to kind of be a little bit more cognizant of that there is a difference between 15 and 30%, because I would question, I think we just did, why aren't those two aligned? And it makes sense with the discussion that we had.
I have a question about how marijuana fits in with the urine drug screen testing and what the expectation will be given that it's legal in this state, and also thoughts from the pharmacists and prescribers about alcohol.
So
because that's not called
we
out.
had a discussion internally quite a bit about that. We decided to not call out marijuana use because it kind of varies by provider what their tolerance is of, and if it becomes a substance use disorder, so it's not like they're using marijuana on an occasional basis, but they're using it heavily daily, then that would be a contraindication. But that's kind of a clinical judgment on the prescribing provider's part. And the same thing with alcohol. Occasional alcohol use may be fine, but heavy daily alcohol use may not be.
I'm wondering if those two things should be identified here, because for marijuana, because it's legal here, I think clinicians don't know what to do. They're really confused, and they don't know if they're going to get in trouble or not. And so being able to say, this is up to your clinical judgment, and if you sense that there's a substance use disorder issue, that might correlate with the problem with opioid use, but use your judgment. I think clinicians really need to hear that, from what I've heard. And sort of similarly for alcohol, to me, I feel like alcohol gets underappreciated and is a sedative. I think there's some significant risks there for people's safety, and it doesn't get identified. It kind of gets completely overlooked in the whole urine drug testing evaluation of substance use disorder issues.
So you would in this section where we talk about no illicit drug use or active substance use disorder, putting in another statement saying, if alcohol and marijuana use rises to substance use disorder, they would be a contraindication, or...
And it's up to clinical judgment. I mean, maybe people could kind of play with wordsmithing that. I'm not sure that the wording necessarily is the same for... for alcohol, I almost feel like it needs to be raised, awareness needs to be raised that is something that it's not illicit, but it's a concern.
So we struggled with this for the last couple of years at our level and within our own Pharmacy and Therapeutics Committee. So the issue comes down to the evidence base, and the evidence base for marijuana is little to none, and therefore we have little to nothing to fall back on to be able to quote or say anything either way. And so the Oregon Medical Board has remained silent for the most part. Most recently, they've changed their stance in the last 2 to 3 years. And if you start there and you follow all the links and go through everything, it all comes back to, I think, the Oregon Pain Commission's document, which also remains relatively silent. So putting that language in there at this point will complicate things again at our level when we're trying to follow something very prescriptively and allow or disallow things based on evidence when there just simply is no evidence. So I understand and share your concerns. Alcohol is a whole different thing, and again, we just went through this this week and have done exactly what you just said. We have raised the alcohol concern significantly in our PA criteria for opioids, and our prescribers in our group felt like we needed to leave the marijuana issue alone at this point and leave that up to the individual prescribers, because it is so unclear and murky at this point. Not that it's not concerning, but the problem is operationally we have to have some good evidence, and we don't have any.
So you're recommending just keeping the wording where if substance use disorder of any type of substance is a contraindication?
I'm not against adding, including alcohol, or...
I just leave it as is.
But we are all acutely aware at our level, and I believe that it's being dealt with appropriately, the alcohol.
Well, if we could just talk about marijuana for just a moment and then talk about alcohol, because I think they're separate things. What I'm recommending, I think, is just a wording that says marijuana use is, that's a clinical discretion conversation to have.
I think what I'm hearing is that would be problematic.
Even if you just said that?
Yeah, I think it's just, right. I think it's already in the guideline, the issue of substance use disorder. And,
except if you...
I just want to make a time call. We have about 10 minutes, and I really was hoping to get through the whole opioid section before we had public testimony.
Can I make one comment?
I am sorry.
Can I make one comment about the evidence? So there is a quite large body of evidence around cannabis and cannabinoids and chronic pain. The challenge with that body of evidence is twofold. One is that many of the studies lump all sorts of chronic pain patients together, so it's hard to pull out and say for fibromyalgia, for low back pain, so it's lots of, but then there's physiologic evidence that probably these patients have more in common than they have difference, okay? And then the second issue is that there are more studies with pharmacologic products like the Naboxamils and Nabilone and things like that than there are with inhaled cannabis, but there is grade 1 evidence for several issues around cannabis.
But there's no evidence jointly with opioids.
So the
there's-
evidence with opioids is open-label, prospective, pragmatic trials, and lots of retrospective recall sort of things. And there is a $2.4 million NIDA-funded study going on right now to look at, can you use cannabis to, in a prescriptive way, reduce the total opioid dose. So of course, NIDA is not going to fund a study that didn't have enough evidence to say that this is theoretically a thing that, that should be looked at in a practical way. So do we have the exact formula for how much cannabis and what type to reduce opioids? We don't have that yet. That's what that study's about. But we do have enough evidence that I think it's probably not fair anymore to say we don't have evidence or there is not an evidence base.
But there's not an evidence base of its use in the context of opioid usage.
So
And that's
if
where...
it would help, I would be more than happy to do a 10-minute PowerPoint at some point about where that level of evidence is.
I don't know that would help in this discussion today.
Okay.
So I'm hearing a strong feeling we should leave wording as is, and also a strong feeling that we should consider looking at the wording. So I can take that kind of split decision to the HERC and just explain that there was some concern that we might need to address this.
And I would just add, if you look back at the wording of the SBIRT, it leads to the idea that if you consumed marijuana once in the last year, that you need to go to the next level of evaluation of substance use disorder. And I think that really leaves clinicians not knowing what the heck to do about something that they, maybe doesn't need to be raised to that level in this state at this time.
And I know that there's a wide variation, and some clinicians feel that any marijuana use is a contraindication, and others feel that it's, a non-substance use version. So fine. So I think that there's no standard issue.
Yeah. And the alcohol question is, it seems to me, again, I would ask the prescribers and pharmacists, but it seems like if I understand it correctly, because alcohol is sedating. If you don't have a substance use disorder, but you have 8 drinks and then you take your opioid dosage, that's a problem. Is that a substance use disorder? I don't know. But
you don't call that binge drinking?
Yeah. Well, yeah, maybe. Okay, that was hyperbole.
But even, when people do fatal overdoses, frequently they find a combination.
Yeah,
benzodiazepines are the
it's
easy
New Year's
one.
coming up. People drink more than they otherwise would. Practically speaking, and a lot of people do that. So
I think that comes up in the materials risk discussion when anybody.
Okay.
All right, so I will leave in the wording as it stands, and we'll let the HERC know that there was some robust discussion about possibly altering that. All right, moving on. The next section is for the centralized chronic pain syndromes, fibromyalgia, and then the...
I'm sorry, Erin, I had one other question.
Of course, yeah.
I got distracted by all this. I'm sorry. Could somebody give me just a quick explanation why you cannot raise the dose of opioids for an acute exacerbation of a chronic problem? So, even for a course of a couple of days or something like that.
So Kat Livingston did more of that specific evidence review, but the evidence is that it's not helpful, that you need to be recruiting other modalities at that point to deal with the flare, and that typically what happens is that you end up escalating the dose rather than just treating the flare. Any other questions? So now we'll move on to the, opioid tapering for fibromyalgia and centralized pain syndromes, which may be coded as chronic pain syndrome, may be coded as something else. And then any patient also who fails to meet the opioid guidelines that were outlined above. So if a patient has a UDS that shows illicit substances, or they're diverting, or that they've got multiple prescriptions from physicians, whatever the reason would be, that they're no longer qualifying under the guideline. So in those situations, then tapering is indicated. It should be done on an individualized basis with a goal of 0. There's unidirectional, meaning continuously down, but there was a generally suggested 5 to 10% per month decrease monthly, but this would be something that would be individualized between the patient and the provider. It might be faster, it might be slower. It would need to include non-pharmacologic treatment strategies to help to manage the pain. In certain situations, so if a patient has aberrant behavior, et cetera, more rapid tapering or transition to a medicated assisted treatment may be appropriate, and it would be directed there by the prescribing provider. And if there is an opioid use disorder that's developed, then treatment for that is on line 4. So basically what we did was we said that they should be going down. We have a goal for the rate of decrease, but it's going to be individualized between the patient and their provider. And the goal is 0. It may take a while to get there.
So we're not having a timeline. It could be an indefinite timeline.
I mean, eventually it will.
Right.
If you go down by 1 pill per month, then
Right.
it
So
may take years.
It may
but
take years to get to 0. Okay.
Or it may be short, depending on the patient and what their needs are and what the provider feels is best for them.
Thanks.
So what about?
Hello, this is Mark Stevens. Can I make a comment here about the speed of tapering?
I'm sorry, we're taking testimony from the public at 11, so we're just restricting comments to members at this point in time.
Okay.
So my question is what about the situation where a patient becomes stable, and, reaches a floor of improvement and can't improve down to 0?
Yeah.
I mean, again, the question is can you then find that line of stability, that dose of opioids, and stay there indefinitely?
So this group that is requested for tapering would be the group of patients who don't qualify for opioids anymore under the guideline. So they shouldn't be on opioids. They should be tapered off. So, if they're actively using other substances, they're diverting, those types of things. And it would also be for centralized pain, and the evidence for centralized pain is that opioids are not effective or possibly harmful. So in that specific situation of centralized pain, they shouldn't reach a stable level because it's not an effective therapy.
It's important to understand that this part about tapering is not everybody who's on opioids ever for anything. It's specific to the conditions, like Ariel said, where opioids have been found to be harmful. And I think that's part of the problem that we had with our public concern, is that they generalize this direction to anything that anybody could take opioids for, and that's not the intent of this guideline.
Exactly, thank you.
Oh, okay, maybe possibly just in that if patient is already receiving chronic opioid therapy, it does say for these conditions. I'm sorry, I missed that. I read it too quickly.
But thank you for calling that out, because I think that's a good thing to make sure we're all really clear on.
I couldn't hear that on the phone. What was that comment?
Could you use the microphone, Mitch?
So Mitch Haas was asking about this specific section that we just talked about, what would happen if a patient finds a stable level of opioids and they can't be tapered to 0. And the response to that is that this paragraph deals only with those patients for whom opioids are really contraindicated. They either have some type of thing that they fell out of the guideline, like an active substance use disorder, or they have a centralized pain syndrome where opioids are contraindicated, and therefore you can't get to a stable dose until you're at 0. But this paragraph applies to this very, very specific population of individuals.
Okay.
Any other questions?
Can I just make a comment? I'd love to hear if task force members have any comments on what I shared in my opening remarks, whereby we gave the 5 to 10% generalized kind of goalpost, but that the intent is that this is individualized, and I want to make sure that comes across clear to you, if you have any suggestions on that language.
It's clear to me.
I think it's reasonable. It's interesting because it actually falls about equivalent to what we had discussed before when we tried to set a timeline as a guidepost. And perhaps this is a better way to communicate that obviously we always individualize and we take specific patient factors into account. The guideline is intended, though, to guide us. So I think this is a reasonable compromise.
And I think it can give providers as
Yep.
well, if they're sort of like, do I take them down to 50% a month? I mean, what do I do? It can give them some baseline.
This is Jim Shanes. Can I share for a second with the group members a project that I'm involved in that you may or may not know about? Essentially, a group of us from around the country have been working on how do we deal with the legacy patients that should never have been put on opioids in the first place, but find themselves at dangerously high doses, and how do you help healthcare providers kind of walk through the evaluation and tapering process? And it relates a lot to this, and the only thing I would add is that we have buprenorphine built in throughout the tapering algorithm, such that people can be identified as having opiate use disorder or having risks greater than benefits, and they can't taper. How does a recommendation like that fit into the work we're doing?
So we do actually, we don't call out buprenorphine by name, we call out medication-assisted treatment. So basically, we call it out in the situations where they need an active taper, but it also does say that transition to medicated-assisted treatment may be appropriate. And that would be an option always, but at the discretion of the provider, and it is part of the provider-patient plan.
Right. We ended up feeling like that was a very strong component in order to balance out the risk-benefit situation that you're dealing with every time you assess the patient.
And to get back to the original question, I think that there's two things that I think that are really helpful with the way.
Any other?
Can I just wanted to point out that in the non-opioid pain guideline, it calls out specifically active therapy that they need to be under, and the taper calls out for non-pharmacological therapy, but the opioid guidelines don't call out that the patient needs to be using any non-opioid or non-pharmacological therapy. And I think that might be an important consideration.
So we talk about there needs to be active therapy or continuing maintenance of self-management strategies. So we could.
And the taper plan also calls out non-pharmacological treatment, but I think that's maybe something that's missing from the opioid prescribing.
The part of the opioid guideline that says that you need, you need to have concurrent.
Yeah.
I think we talk about that in the back opioid guideline. So let me see if we have what the wording there is.
I'm just asking for consistency.
Yeah. No, but I also think that's important. What we have talked about in the back opioid guideline is when it needs to be co-prescribed with a plan to keep active and with consideration for additional therapies such as spinal manipulation, physical therapy, yoga, acupuncture. We could take that sentence
and make sure that that's addressed in the opioid prescribing. Yeah.
So you're suggesting putting something like what's in the back, and then we would drop that into the long list of things under the opioid guideline. Does that make sense? Do you guys understand what we're?
And you mean in the taper? No,
Not
I mean
in the
it's
taper.
called out in the taper and it's called out in the non-opioid, but as far as the opioid prescribing guidelines, There's nothing specifically saying that in order to prescribe opioids for these patients, they also must be on some non-opioid or non-pharmacological treatment. And I think that's important.
But this is not perfectly wordsmith, but what I just did was I went to the back opioid guideline and pulled out their sentence. So we have things like patient and provider should assess risk, the patient needs to have a pain education module, and then needs to be prescribed with a plan to keep active, home or prescribed exercise regimen, and with consideration for additional therapies such as physical therapy, yoga, or acupuncture. So kind of calling it out that when you're prescribing opioids, you need to co-prescribe something else.
I guess my question is, so I'm hearing the words need and must in that language, and then we're talking about individualized plans and flexibility in the current language, and how do those two kind of work with each other?
So actually, in the opioid guideline, this is actually almost more of a need or a must. You must do a urine drug screen. You must have the risk assessments, those types of things. So it must be prescribed with something else.
To prescribe initially.
Yeah, to be on opioid therapy for the non-centralized pain, and then again, it would be up to the provider and the patient which of those they want to do. Does anyone object to that? I mean, obviously, we will need to maybe wordsmith this and make it sound nicer, but.
Try to type it in here if you want me to.
Sure.
And the wording is focused around staying active, but did not also include mindfulness or psychological intervention.
I think you can keep it fairly general and say
I think it should be included.
Non-pharmacological treatment is also being
Yeah,
prescribed.
I think that's better.
Make it look like the other guidelines.
Yeah, I think that's better. So as opposed to just focusing on activity, that it be non-pharmacological treatment interventions, which would also include mindfulness practice and cognitive behavioral therapy.
I didn't catch all that. Okay, so.
Non-pharmacological treatment options, as opposed to calling out activity in specific, which would leave out mindfulness practice and cognitive behavioral therapy.
So just when prescribed with non-pharmacologic treatment options.
And actually, I think the wording was active interventions, which it wasn't about activity, it was active interventions, things the patient does. Meditates, does yoga, starts walking. That's what the back pain guideline has as part of opioid prescribing, if I remember correctly.
Ariel, to the earlier point, there's also, you could just lift the same language that's included in the taper in the non-opioid pharmacological and just keep it consistent in this guideline.
So what Dana is suggesting would be when prescribed with non-pharmacologic treatment options for managing pain. It's exactly the word from the wording from the taper. And that could be any type of therapy that the provider feels.
Well, although non-pharmacological could be surgery, and that's not what we are getting at. We are getting at things people do.
Yeah, like the day-to-day. I mean, when I'm looking at it, I would be looking at what are they also doing day-to-day besides
Exactly.
taking an opioid to help.
I think for simplicity and to move on, I would agree. Let's lift the language from the other pieces, the other guidelines that should align, just make them look similar.
Okay. So I lifted the words from the taper. Okay. We're ready to move on? So the next section is the line scoring. This also didn't change from what you saw in June. Just for reference, line 401.
Ariel, I think we need a brief break.
A 5-minute break would be lovely. All right.
To the potential harms or benefit to patients. Many patients who stand to be affected by this proposed policy currently benefit from long-term opioid therapy to manage their complex conditions, maintain their quality of life, and participate in activities of daily living. We observe that the task force proposals are not supported by the very evidence review it commissioned. According to the review, there was scant evidence of harms associated with the tapering strategies. Okay, fast forward. Let me see. The Oregon, I'm going to skip through a little bit. The Oregon Chronic Pain Task Force is proceeding with a proposal to reduce patients to either 0 MME, 50 MME, or in exceptional circumstances, which are undefined, up to 90 MME, despite its own contractors finding that the evidence to support non-consensual mandatory forced tapering is weak to non-existent. The evidence regarding harms is not yet collected or analyzed. Let me see if there's... It's time? Okay.
But you're submitting that, right? All this is being submitted.
This'll, yeah, you guys should probably already have a copy of this.
Great, thank you.
Hi, my name is Eve Blackburn, and I don't have any conflicts of interest. I'm a chronic pain patient and advocate. I want to read a letter from the American Medical Association that was dated November 13th, 2018, and it's titled Resolution 235, Inappropriate Use of CDC Guidelines for Prescribing Opioids. It was passed by the AMA House of Delegates on the 13th of November. Resolved that our AMA actively continue to communicate and engage with the nation's largest pharmacy chains, pharmacy benefit managers, National Association of Insurance Commissioners, etc., in opposition to communications being sent to physicians that include a blanket prescription against filing prescriptions for opioids that exceed numerical thresholds without taking into account the diagnosis and previous response to treatment for a patient with any clinical nuances that would support such prescribing as falling within standards of good quality patient care. Resolved that our AMA affirms that some patients with acute or chronic pain can benefit from taking opioid pain medications at doses greater than generally recommended by the CDC guidelines for prescribing opioids for chronic pain, and that such care may be medically necessary and appropriate, and be it further resolved that our AMA advocate against misapplication of the CDC guidelines for prescribing opioids by pharmacists, health insurers, pharmacy benefit managers, legislatures, and governmental and private regulatory bodies in ways that prevent or limit patients' medical access to opioid analgesia, and be it further resolved that our AMA advocate that no entity should use MME, morphine milligram equivalent thresholds, as anything more than a guidance. And physicians should not be subject to professional disciplines, loss of board certification, loss of clinical privileges, criminal prosecution, civil liability, or any other penalties or practice limitations solely for prescribing opioids at a quantitative level above MME thresholds found in the CDC guideline for prescribing opioids for chronic pain. And I just want, this is a question, but you don't need to answer it. And it's, the centralized pain syndrome, if you have a diagnosis of that, but you also have a diagnosis that has a chronic pain condition that's covered for opioid therapy, are you disqualified? So that's something to think about. And the other thing is perhaps we could be pointed to some data on the number of Medicaid patients that would be affected by the policies being proposed. If we could be pointed to where we could find those numbers. Like the number of people that are currently on over than 50 MME, we'd like to know the amounts that are going to be affected. Thank you.
Next we have Amara and Laura.
Going to read a little bit of an analysis.
Could you identify yourself, please?
Amara. This analysis was done on the study that was referenced in the revisal, comparing pain and depressive symptoms in chronic opioid therapy patients receiving dose reduction and risk mitigation initiatives with usual care. I'm going to be reading from a compilation prepared by Cindy Hounhouse, the Alliance for the Treatment of Intractable Pain. Contradictions. The study is of poor quality. The study is relevant to Oregon proposal. The study lacks crucial background information regarding pre- and post-tapering outcomes. Lacks specific evidence verifying patient tapers. Low patient participation, leaving large percentages of patient outcomes unaccounted for. No patient baseline controls for proper analysis. Uncounted for discrepancies in outcome scores. The new study provided by the Chronic Pain Task Force offers no scientific evidence to support mandatory undirectional tapers to 0 MED or otherwise for Medicaid patients. The MED updated report on tapering or discontinuing opioid use among patients with chronic non-cancer pain discloses that no study was rated as having good methodological quality. The overall quality of evidence was downgraded to very low for each of these outcomes. Pain, function, and quality of life, its overall quality of evidence was rated as very low for effectiveness of strategies to reduce or discontinue opioids, based on serious risk of bias and indirectness. The study is irrelevant to the Chronic Pain Task Force proposal. The Chronic Pain Task Force is comparing risk mitigation involving potential tapers to at or below 120 MED to tapers of all Medicaid patients to 0 MED or 50 MED. It's in distinguishing circumstances. The task force's proposal is a direct contradiction of the CDC guidelines and its Canadian counterparts. Its restrictions are unprecedented in the US and even the world. The CDC lists reasons for tapering. Patient requests a dose reduction. Patient dose does not clinically have meaning, or do we see improvement in pain and function. Dose of 50 MME a day without benefit or opioids are combined with benzos. Shows signs of substance use disorder. Experiences overdose or other serious adverse events. Shows early warning signs of overdose risk, such as confusion, sedation, or slurred speech. Reasons for tapering listed in the Washington prescribing rules. The patient requests, the patient experiences a deterioration in function or pain. The patient is non-compliant with the written agreement. Other treatments, modalities are indicated. Evidence of misuse, abuse, substance use disorder, or diversion. The patient experiences a severe adverse event or overdose. Unauthorized escalation of dose. An authorized escalation of dose with no improvement in pain or function. The study is void of crucial background information comparing patient outcomes before and after a taper is initiated for the group practice participants. Yet this is the basis Oregon is relying on to support mandatory tapers.
Thank you.
Hi, my name is Jacqueline Connor, in for Laura. I don't have anything to read. I didn't bring evidence with me, though I have a lot of it in my brain because I'm not really sure how any of you would react to that. And I don't have a story, but I have a few points that I think are important to bring up. That today you stated that tapering is not intended for everyone, and the act of tapering and how long that takes and the percentage should be individualized between a patient and a physician. Yet by stating there are only certain conditions that would apply for people being able to take opioids for certain conditions, that is not stated to be individualized between a patient and a physician. You also have put out that you think everyone should be tapered to under 50 MME, but that also brings up the first point of how long tapering takes, and then under 50 MME, taking away, that should be individualized between a patient and a physician. Also, people that are taking these medications for chronic pain long term are generally on a higher dose. 50 MME is 30 milligrams of oxycodone. Someone that's been taking these medications for 10, 15, 20 years and has a highly painful condition, that's just not enough for those. It's just not enough. There's also, you're stating people can be tagged for substance use disorder and then they should be tapered down. But if I go in and I'm doing everything right, I go in and take my urinalysis and something comes back where it's a false positive or a false negative, and I know that's wrong, then people that are doing everything right from one lab test can have everything taken away. And I think that should be something that could be noted on maybe how to better test, maybe do a blood test for that. I just think there are few things that need to be maybe looked at a little more as far as the tapering, what's supposed to be individualized, and the dose at 50 MME. I also, if I were to go in and my doctor thinks I have substance use disorder, it's written that I could then start taking methadone for a substance use disorder, which if I was taking methadone for pain and had substance use disorder, I would no longer be able to take methadone. So that's kind of, I can take it, if I say I have substance use disorder, then I can get pain medication. And that just seems a little murky, if something you might want to think of. So that's all I have to say. I think my time's up.
Thank you.
Thank you.
Next is Kaylee and Kelly.
Are you guys going to quantify what or explain what the extenuating circumstances are for anything over 50 MME? I don't see that anywhere. Okay, that one.
Excuse me, if the other hasn't shown up, I would like to change my mind. I'm super tonight and said no, but I would like to take 3 minutes.
I'm sorry, I can't hear you on the phone.
Okay.
Okay, so one of the things that we...
Can you please state your name?
Oh, excuse me, I'm sorry. My name is Kaylee Cresta. Primarily, I'm a patient that benefits from high-dose opioids. I have a very, very rare condition, and I look at something like this, and there's nobody's taken account for those very, very rare conditions. Ultimately, you could call anything a centralized pain condition. It's a discretionary term. Now, people don't have the right to go from one doctor to another doctor with obvious reasons. There can absolutely be problems there. But when you have a discretionary term that could dictate whether or not somebody is allowed to take opioid medication, that's really a very dangerous thing to do to a population of patients. This right here that I have in front of me, just of course for the sake of time, talks about the Washington Medical Commission that's revised and updated their opioid prescribing rules effective January 1st of 2019, which talks about non-treatment, under-treatment, over-treatment. They're all inappropriate treatments of pain. And we have to look at something like this as could absolutely potentially under-treat pain. What is the difference? We're looking at an arbitrary threshold like 90 MME, which was just the American Medical Association just 2 weeks ago rejected the weaponization of the CDC guidelines. And yet the AMA came out and said that, and yet we're still seeing a 50 to 90 MME threshold here. You can't get over 50 MME unless it's extenuating circumstances, and there's nothing here for people that 90 MME may not do it. For a patient like me, and it's not about me, it's about thousands of people like me on Medicare and Medicaid, but somebody like me, my bones are going to break if you were to take me and put me to a 90 MME. And how many patients are there? Has that been evaluated at all? Is there any data there? And how can we walk into this not knowing what a centralized pain condition is? Patients don't even know what that means. Patients don't even know if they're going to necessarily be affected because they don't know what a centralized pain condition is. That hasn't been laid out. No, you can't prepare for it. And even if you could prepare for it, some people simply cannot live on that MME.
That's very dangerous. And so we talk about some disease processes that this is contraindicated. I don't see the statistics of that. I think it's very important to disclose them if they're there. I don't believe they are. And if they are, there's going to be a much greater loss of life if you implement these policies. Thank you.
Hi, thanks for letting me in. My name's Sue Griffin. I'm a chronic pain patient. I have been since I was young, feeling old these days, as arthritis and such complicates my system. I am the normal person. I've done the administrative jobs. I've been a manager. I've succeeded in this life, except I go through periods where my back is, I have a lot of problems. I've had 2 failed surgeries. I've been denied right now through OHA for a multi-level fusion, and my orthopedic is working on getting that turned around. I have been subscribed to opioids over 27 years, on and off. I have good times, bad times, and my body may adjust to handling, or I found another way to deal with my pain, and then something new comes along. I've been thrown off a horse, I've, skiing accident, all kinds of things, and just trying to have a good time. And I suffer a lot. Right now, I currently have a good doctor. I've always had a good doctor who is very compassionate and willing to work with me. However, there is a constant threat hanging over us. He says that any time I could be one of the patients that is to be, whatever terminology. Fortunately, I guess I have enough in my background. I'm 56 years old. I have enough complications in my back that I'm not that person, but I read those people's letters. I admin a Facebook group. I see suicidal people. The stories are, my doctors, they had to take me off because the guidelines say, I hope you all understand that you're calling them guidelines and it's discretionary between the patient and the physician. That's not how it's working out there. There's indoctrination from, I don't know, the attorneys, from the clinic board member, whatever it might be. You have this nice little panacea about, well, it's up to the doctor, and it doesn't happen. The doctors are threatened and they're stopping. They're leaving profession. They're leaving their profession even. So what else did I want to make sure? I wonder why massage therapy is not a modality. I find it beneficial in my condition that I additionally have a lot of muscle problems. Massage therapy I have to pay for on my own. That would be it. Thank you.
Thank you. Shani Mason and Cherry Amabisson. Thank you.
Good morning. My name is Shani Mason, and I'm here today on behalf of the Oregon Medical Association. And I'm going to read a letter that was prepared collaboratively between the Oregon Medical Association and the American Medical Association. Can I borrow that pad of paper? I don't have my reading glasses, so I need to use this to make sure I don't miss something. The Oregon Medical Association, the OMA, and the American Medical Association would like to thank the HURT Chronic Pain Task Force for the time and effort it invested in creating the proposed recommendations. The misuse and overuse of opioids has created a multifaceted problem. As a result, many varied tools are necessary to combat it. Over the past 5 years, our physicians have been at the front lines working to turn the tide. The Oregon Medical Association is a professional society engaging in advocacy, community building, and networking opportunities for the healthcare community in our state. The association's primary aim is to serve and support our nearly 8,000 physician assistant, and student members in their efforts to improve the health of Oregonians. The American Medical Association is the premier national organization providing timely, essential resources to empower physicians, residents, and medical students to succeed at every phase of their medical lives. Physicians have entrusted the AMA to advance the art and science of medicine and the betterment of public health on behalf of patients for more than 170 years. In Oregon, enhancing the prescription drug monitoring program, providing education to our members, and assisting in the development of prescribing guidelines are just a few of the methods necessary to ensure that opioids are used in an appropriate manner. As one measure of the effort physicians have made in Oregon, opioid prescribing has decreased by 25.5% between 2013 and 2017, according to data provided by IQVIA, a health information company. Nationally, opioid prescribing has decreased 22.2%, a sign of progress, but one that must be tempered by two facts. The opioid epidemic now is being fueled by heroin and illicit fentanyl overdoses, and we're actually aware that patients with pain often have extreme difficulty accessing comprehensive multimodal pain care, including non-opioid pain care alternatives. Ensuring access to this care is one of the main recommendations of the AOMA task force. Did that say 30 seconds? Okay, I'm going to skip then to our recommendations at the very end. Our following considerations: maintain the integrity of the provider-patient relationship by ensuring that the physician or physician assistant may continue to prescribe based on the individual history and needs of each particular patient. Utilize evidence-based practices in the development of tapering recommendations. Where specific goals are identified, ensure that language supports those goals as a target to work towards, not a hard and fast metric that could have unintended harmful consequences, and ensure that quantitative goals are measurable and not utilized by payers to increase the administrative burden on patients and providers, specifically through the prior authorization process. Thank you. That was Dr. Williams, who is the president of OMA, and James Madera, who's the CEO and executive director of the AMA.
Thank you very much.
Honorable Commissioners, my name is Cherry Amabiska, and I've had the honor of taking care of a number of family members over the last 15, 20 years who have had very severe pain issue structures, in addition to some mental issues. So they've had complex medical issues. My concerns right now, I'm taking care of two family members who live with me. One is on Medicare, Social Security Disability, and one is on Medicaid in Oregon here. My concern is the difference in treatment that your proposal is going to cause, because the Medicare patient is able to have opiates, goes to alternative treatments, the restrictions are less. She's on less than 90 MME a day. So if you implement your proposal for Medicaid, the Medicaid patient I have won't be able to get the opiates that he is currently on and stable with and doing well with. And it will be I think it's a very disconcerting to have such two different treatments for pretty much the same conditions, but because of the plans, the two different plans, it's going to be hard for me to explain to that Medicaid patient, sorry, you don't get any opiates, but your relative can, living in the same house. I don't understand why you want to have Oregon be the only state in the country that has such a punitive approach to opiates and the forced tapering. My brother was on opiates after 30 surgeries. They helped him quite a bit. He was with the VA in California. they forced tapered him, and he had told us very clearly for years before that when his pain got too great and it wasn't going to be able to be controlled, he would take his life. And sure enough, the forced tapering is what did it. I think you are underestimating the benefits of opiates to people who are stable and have complex situations. What happens if alternate treatments do not work? The 2 patients I have right now have had hundreds of, no offense to the alternative treatment people, but they've had hundreds of treatments of acupuncture, physical therapy, chiropractic, mindfulness, and they say that PT gets them stronger, but it doesn't help the pain. So my concern is if alternate treatments don't work, they're off their opiates, what do? They're prime candidates for suicide. Thank you very much.
Thank you. Alan Chino, and I have a Laura Stollard as a maybe. No? Okay.
Good morning. I'm Dr. Alan Chino. I'll be as brief as I possibly can be. I know I have 3 minutes here. I have a fair amount of credentials relating to treating pain. By the way, I'm a medical psychologist, past president of the American Academy of Clinical Health Psychology, past director of the Oregon Psychological Association, spent 2 terms on the Oregon Pain Management Commission here in the early 2000s, up to 2009, I think. I have a clinical appointment at OHSU. So I have some credentials, but I'm speaking for myself today. I'm currently a private practitioner, and I see a lot of people with chronic pain, have over the years, probably the past 30-some years. I developed and directed 2 hospital-based pain centers in California in the past, got them both accredited, and then was recruited and directed a 3rd accredited program here in Oregon. Again, that's part of my history. I'm just kind of establishing that I've been around a lot of chronic pain patients. I've tried a lot of different things. I'm a researcher as well. I've got that kind of mindset. So I've been able to observe over the years what works and what doesn't work. I want to just provide you with some recommendations from me to you guys. By the way, this is a substantial work product that I was able to review in terms of your guidelines and proposals here. So you're to be commended on that, and I can sense people care. I co-authored this book with a physician colleague. It's called Validate Your Pain. It's 3 editions. Chapter 7 is entitled Pain Medications and the Fear of Addiction, or Much Ado About Almost Nothing. And in that chapter, we review the literature. This is up to 2005, so it's a bit dated. But I think the conclusions are basically the same. Let me tell you what's happening out there in the clinical world, at least as I see it. There's a lot of fear being produced among clinicians, among patients. The more fear you add to any system, the worse your outcomes are going to be, especially in terms of a clinical situation. And indeed, I think that's exactly what's happening. There is a sociocultural movement going on, the opioid epidemic's in the news. When people think about somebody on chronic opioid medications, they think of the addict. They don't think of my patients. I have so many patients who are doing markedly well and have done so for years on chronic opioid therapy. They're stable, they're functioning. They have been in situations, and they remember, because their doctors are now afraid and talking about doing tapers or instituting tapers. They remember days when their pain was not controlled, and it's sparking a lot of fear in the patient. The psychobiology of pain, you probably already know about that. They get worse. They're showing more symptoms. Now, my job as a medical psychologist is to help them get in the best position possible to take control of their pain condition and hopefully to taper off. But why we are looking to taper everybody to 0, it's beyond me. I don't understand that. Ostensibly, it's because there's something dangerous If we don't do that, I think that's a premature conclusion. My time's up. Thank you so much.
Great, thank you all. We really appreciate all your input and you taking the time out of your Wednesday morning and coming and joining us, so thank you very much. We have a half hour left, and this time is for the task force to kind of mull over everything that we've heard and read. I just want to reflect a little bit myself. One of the things that I think we really need to pull out of all of this, which is that we're really trying to add benefits. Currently, folks with fibromyalgia and chronic pain syndrome, according to the prioritized list, have no treatments available, and we know that that's not appropriate. So I think the real pull, the real product of this group is to really try to move forward in giving those patients a lot more tools than they have now, so that we can, really address their pain and improve their life. So I just wanted to make sure that gets called out. What I was hoping to do with the next 15 or 20 minutes is just to kind of take a step back as a group and see if any of you all have any, having heard testimony, having heard all the discussion this morning, if you have any additional thoughts that haven't been called out, any other input, anything that you think we got particularly right, or anything you think is still not quite right or that you don't agree with. Just kind of just to step back and reflect a little bit. I don't know if anyone wants to start.
So this is Kim. I think one of the things that you really got right was this idea of individualized between the prescriber and the patient. And I don't know how we really help prescribers see that, because there is fear in the prescribing community that, that this will be seen as some sort of dictate, and sort of the playing up that it's individualized, I think, will be helped. Key's letter from Stanford University, he calls out the same studies about tramadol and occurring here in Oregon and being appropriate for fibromyalgia.
Anything that hasn't come out that you just want to make sure it gets thrown on the table, or?
Nothing that's already come out. I just want to kind of second Kim's kind of point, because the goal behind this is helping people get better, and you did incorporate that individualized aspect to it without taking, really providing an open end, which really enhances that physician-patient relationship, which I think was really, really ideal. I think the other thing is to remember is a lot of the other things that tend to get missed here, again, as a pain education standpoint, becomes really, really important. We've tried to call that out multiple times. I do think it gets overlooked over and over and over again. There's a lot to pain that has evolved, particularly in the last 20 years and certainly within the last 10 years, that is that people just are assuming they already understand without taking the time to actually go through it. And I think that's important, that when we start understanding this stuff better, when we start understanding how medications work. And it's really interesting on the opioid literature that the effects when you're looking at them chronically work a lot differently than what we initially thought. So I like that we incorporate that, and I do think that having that emphasis on open-endedness and individualization is helpful.
So I just wanted to start by thanking all of you that came to testify. I've been on that side, and I appreciate it. It can be very nerve-wracking. And Ariel, I like the new format that we did today, where we had time to listen to the testimony and then time to discuss afterwards. I think that's a really respectful way to process the comments that are brought to us. I did have one comment that was brought up in one of the letters, I think, from the OMA about the access to the non-pharmacological therapies. That is an issue that patients do have trouble accessing behavioral health, acupuncture, chiropractic, physical therapy due to prior authorization requirements, and it can be very tricky navigating that process. And so if there's some way that we can ensure that then when we're saying we're offering this benefit, I said this last time, that we really are offering these benefits.
And again, that comes down to contracting with the plans. I think the plans have been doing a really good job trying to expand their networks and trying to work with their communities, and there's room for improvement, I'm sure.
When you've got someone in pain right now, and they've got to wait 6 weeks before they get into a provider, that's not how it should work.
This is Kim. I have one other suggestion. I think that if, however this form moves forward, we should be very intentional about collecting data around outcomes. And as one said, how many people are we talking about exactly, and what sort of outcomes might we look for at 6 months, 9 months, 12 months, et cetera, because this is different than what's done nationally.
That's a great point, and I think internally at OHA, I think we're interested in coming up with something, but that's something that we'll have to flesh out a little more in the evaluation plan.
This is Nora. I want to echo what Dr. Coccaro had said about the importance of us as a whole society understanding pain better now and spreading that knowledge among the clinical community and patient community. And I think this new guideline did a good job of calling out the resources that we have in the state in terms of the pain education module for clinicians through the Pain Commission and the upcoming patient pain education module, which I hope will be very useful for clinicians to use with their patients and for them to use on their own to start to see some of the places that they might have opportunities to change their pain that they didn't think they had. So I think that's good. And I also want to reiterate, because some testimony had talked about whether this would deal with rare conditions, and I want to echo again that there were 5 specific diagnoses that these guidelines cover, and rare conditions that are not part of those diagnostic codes would not be part of that, and so wouldn't be affected by these guidelines.
Anything that we didn't talk about that you want to make sure it's something that's been bothering you, or something that you've kind of that's come up during discussions or hearing testimony? Okay.
This is Amber Rose. I'm not quite sure exactly how to state this, but as I was listening to the testimony, just again the fear that is out there, and the real life examples of what's happening on the ground between practitioners and patients, and I know it's kind of beyond the scope of HERC and OHP necessarily in terms of everybody, but I think we have an opportunity as a task force to try and address the fear, and to I think we've said it, but I'm concerned that it's not being heard. That part of what we're doing is increasing coverage for this, that these were things that were not covered at all. So if somebody's been seeing a doctor under the Oregon Health Plan and they've been getting opioids, this line would not have any effect, because if they had gone to a practitioner prior, they wouldn't have gotten any treatment. And I'm not sure that that's been communicated clearly enough. As somebody who lives with fibromyalgia and has been on the Oregon Health Plan, I'm no longer on that. I am employed by a company, so I have health care outside of that. But when I was, I had no treatment for my fibromyalgia. So I don't know the answer, but it concerns me that there continues to be a lot of fear on all sides of this issue. The patients, the practitioners, and the administrators trying to figure out how to do this well, to do this efficiently, and to do it in a fiscal, responsible way. So, you know, as we're sending our recommendations back to HERC, I think it's important that complexity somehow gets communicated. And I'm not sure that what we're sending back to them at this point necessarily encompasses it, because it's not being heard when it's been put out there. So that's my concern.
Arachnoiditis is a rare condition, and centralized nerve syndrome is one of the symptoms of that, by the way. So
Okay.
I just wanted to point that
Any
out.
other thoughts by members?
Okay, so I just wanted to kind of review our next steps. I heard some definite suggestions for improvements for certain areas, like adding in the need for other therapies in the opioid section. And so we'll do, I think the overall changes that you all had recommended are rather minor. I do have some notes about things that I need to bring up when we discuss this with the HERC and call out so that they know what wasn't included or what the kind of the thinking was behind certain areas. So there'll be a few minor changes, and after we kind of make a complete final proposal, I'll send that around to everyone in the task force just so that you have a chance to look at it and give any final input if you notice typos or anything like that. This will come to the Value-Based Benefits Subcommittee at our January meeting. And the January meeting, I had it up and I don't, is it's the 17th of January, and it will be in Wilsonville at the Holiday Inn. You all, task force members, are all welcome and invited to come to that meeting. This discussion will probably happen sometime early mid-morning, and you're welcome to call in as well. So if you would like to be part, just send an email or drop a note to staff, just so that we can be aware that you're coming, and we can kind of make sure that you have all the information that you need. So the Value-Based Benefits Subcommittee will consider this in great detail. They will do whatever changes or anything that they feel is appropriate. It will then go to the full HERC for review, most likely in March. And at that point, we do need to make a decision, a go, no go. If they choose to make this will be a new line. It will have some substantial cost associated with it, we assume. So it will have to go to the actuaries and then go to the legislature for approval. And then if anything that is approved by HERC, once it's gone through that whole process, will be effective January 1st, 2020. And then any updates and evidence reviews and sort of outcome types of things would happen after that point.
Ariel, can I just make sure that we give clarification? So for both the VBBS and the HERC, those are, again, public meetings, public process, and opportunity for public input and testimony. So I want to make sure that was really clear as this policy consideration is underway. And then, so confirming that is true. And
So if anyone has any members of the task force, if you have a minority opinion, or any members of the public, you're welcome to submit written testimony up to a week prior to the meeting so that we can post it. We can post it late. It may or may not go into the packets that go out to commissioners. You're welcome to come to the meeting. We will again have public testimony time specifically set aside for this discussion, as well as the general public testimony time for the meeting. So at both VBBS, which is in January, as well as the HERC meeting, which is in March.
And so I just wanted to clarify on the written testimony, if it's submitted at least a week in advance of the meeting, then that gets provided to the members at the time that they get their meeting packets. We do receive or accept written comment up to noon 2 days prior to the meeting, so that Tuesday the 15th, it will still be provided to the members, just not with their packets, so they'll have less time to potentially review it.
And Ariel, I have one other question for the team. So there's been a lot of written testimony submitted to the Chronic Pain Task Force. Will that be collated and advanced to the VBBS as well?
We did that with the August meeting, and we will continue to do that at the January meeting as
Great.
well.
I just wanted everybody to know that that will be passed on for the additional considerations.
And in addition, as staff, we try to summarize the general sort of gist of public testimony. So they have all the public testimony as provided available to them to look at. And then we also try to give a summary to kind of show sort of where the general feelings and thoughts were. All right, do you guys all want 15 minutes of your time back? I wanted yeah, I wanted to thank all the task force members again for your service. I know that this is time out of your busy lives and your professional time, and we really appreciate your expertise and your time and your input and all of your thoughts. So thank you very, very much. There may or may not be another meeting of this task force. We thought we were done in June, and we were wrong. So I'm not going to say anything now, but again, we'll let you know in the future if we need to reconvene to work on any further fine-tuning or issues. But thank you.
I want to echo my thanks too. I appreciate being able to be a part of today's meeting. I've been following along since I've been in my position. And again, just appreciate all your expertise and time commitment. Sorry, Darren, were you going to add?
I was just going to say, because of the timeline that we've got, as Ariel was saying, we've got to have her make a decision in March. I think it's going to be unlikely that we're going to have time to reconvene this whole group. However, there may be specific questions that arise as VBBS and her consider this that we might connect with you and get potentially some input or answers from to take back to the commission at that point. All right. Thank you, everyone.
Thank you.
Well, that could be your name.
I know, likewise. I pulled that
It still works?
Right, like they've got a substance disorder or whatever.
Yeah.
The other ones, the idea for new chronic pain patients can be get 50. If somebody's been getting 120, they should get down to
Yeah,
50.
right.
Unless they have other context.
Right, just like, right. It's clear as mud. So centralized.
Yeah, oh, centralized. That's what my doctor said.
Yeah, all three of those words. Centralized and central.
And I have, okay.
Oh. They don't ask you what it is. That's going to be our highest. We included that.
Next one too.
Yeah, January 17th.
Oh, I can't. It's enough to have to drive home. All right, see you guys.
They aren't all.
I think you were having.
Yeah, they're both the same day. So VBS meets in the morning. No,
Oh, it will.
I mean, it may, if PBS is done with it, unless Darren is. Oh, Darren, well, maybe Darren's planning to have two PBS. Usually things just go.
Yeah, that's lame. You guys going to the meeting in January? Oh,
Well, I had a question for you.
absolutely.
You made a comment about something about your bones would break. What were you talking about?
I have a disease called stiff person syndrome, but it's an atypical presentation, and see toddler just all over the place, troubled everywhere. Let me make sure I have it. Plasmapheresis, therapy. My body was so badly that my bone would break.
From lack of the opioid.
Opioids are the only thing I've literally tried to take.
Okay.
Stem cells, and it's just kind of what got me in this world.
And but your condition you think won't be covered? It's not a centralized syndrome.
My point is kind of this, when this all first started, and I kind of do a lot of journalism type work on chronic pain issues.
You think?
So yeah, when this first started, the reform, I was cut down.
Uh-huh.
And within those 48 hours, both my lungs collapsed and I fractured 6 vertebrae. We'd like to think that all these conditions are going to be exempt, and I get that, and it wasn't going to be inflammatory by any sense, but it's how do we make sure that
Don't try to
interpret it as a centralized pain condition, and that's kind of the
Yeah,
biggest
okay.
concern. Yeah. And that was really
Okay, so that was the point. Okay. Yeah, you got a garbage can. They can discard anybody by just classifying them there.
As a centralized condition.
Yeah.
The only reason I say that is because we the CDC guidelines. They were meant to be just that, guidelines.
Right.
Instead, they became standard of care. And I think that happens, right? Because otherwise, doctors they of course have to live in fear. That's their livelihood. And these guidelines do become adopted as standard of care.
But in the end, a lot of the problem is caused by the doctors themselves.
I don't doubt that there were, and I will never argue that. I don't think any chronic pain patient should say that opioids should be in the kiddie pool. I don't think, anyone would make that argument. Do I think people were prescribed them for stubbing their toe too hard? I would never argue that with anyone. But I think then we have the really legitimate doctors that have a lot of, whether they see a variety of rare disease patients, whether they see,
Right.
and they suffer extreme scrutiny.
It becomes very difficult because you have individual cases and then you have, just the population norms that you have to deal with. And it's very hard.
By any chance?
Do I want to what?
Do you actually want to speak on this, recorded speak on this?
We're just talking.
Okay, I was just checking. I wanted to make sure, because you're saying such wonderful things. I'm sorry.
No, but
I'm enjoying speaking to you. I'm sorry to have interrupted.
No problem. It's when I was reading all the comments some days ago, I was getting, I didn't realize that they had what I was reading. I was having troubles because I had missed a couple of meetings. I was away. But the way people were talking, I'm saying it looks like they're covered here. What's going on? So there still needs some clarification, I think.
Yeah, I think it's always dangerous when we see discretionary terms.
Yeah.
I just think that's an issue.
But so I guess my point is that you want things to be guidelines because you don't want to dumb down
course.
Decision-making by the physicians by having, too constricted guidelines. But on the other hand,
I totally
if you make
see
them
that.
too loose, then they're not even they're nothing. I mean, guidelines just become nonsense. So
It becomes, of course, a bigger issue because, and everything you say is such a valid point. I would never argue with a word that you've said thus far. It's at what point, okay, so we have this epidemic, we have this crisis, we have this fear on our hands, by all means, take them. And then in that same note, how do we stop going into the doctor's office? How do we say that we do have responsible doctors and responsible patients and say we need to stay out of that office?
Right.
How do we make these guidelines before we know how
they
to
try
do it without hurting people?
They try. Yeah, I mean, more and more. I think people are trying to collect data to look into it. Not even that can be dangerous, right? So like Kaiser, they're looking at records. Well, you're prescribing more than average. Well, I see the worst patients and that kind of thing, right?
Right, exactly.
So you have to deal. So it's very hard.
Right.
And
for instance, like my doctor, he's seeing all ALS patients, really rare disease patients. You're talking about extreme pain conditions where I would have, by all means, I would have stayed on chemotherapy for the rest of my life if that did something. It just didn't.
Right.
It wasn't stopping the presentation. It wasn't. So I totally understand. But I don't know how we make that distinction.
That's hard,
Mm-hmm.
and that's kind of compromises. You've got to tweak it as you go along. Essentially, you're going to have to implement it and beta test it. The questions I was asking about harm, they were saying there wasn't much there. Well, harm, you need really big studies
Of course.
to find harm.
Right, and I loved your questions because it was something that I really wanted to hear asked.
Okay, good. The research I've done, we report on harms. Well, sometimes, not always, but it's like, no, they didn't report on harms. Well, given the sample size, it's pointless. What can I tell you? I do back pain research, headaches. All right, so people get a manipulation from a chiropractor and they get a little sore. Well, it's like an injection site from a vaccination. Nobody cares about that really. I mean, even if I don't even know that people collect that kind of information. It's not even it's not well, I get maybe, but it's not something that a data and safety monitoring board or an institutional review board really gives a crap about. And in fact, when NIH told us we had to report everything to the data and safety monitoring board for the last study I did, they were pissed. I said, we don't want to see all this crap. Put it in hierarchical form. What's a real severe thing? Somebody died in a car accident a year after they had the treatment. We don't think that had anything to do with the study. But we report that, and they look and go, But the thing is though, never had a severe adverse event associated with any study done because, we're not collecting hundreds of thousands of patients.
Of course.
It'd be really cool if we could, but you can't. No one's going to pay for it.
Right. That's exactly it. There's no funding.
There's no funding.
Right. Well, short of asking people that would be willing to do it, but then it's not a legitimate study. I'm sure she's going to want that. Another really important point is a true chronic pain patient has no expectation of being pain free. I think the expectation is functional. And so how many, I guess my biggest question would be how many patients after years of chronic pain or painful disease processes can still function off of that 90 MME threshold, 50 MME threshold, depending on your circumstances. 90 is going to be probably small.
And it was an old friend, somebody I knew for years. He committed suicide. He had a very, very severe pain. It was intermittent, but he said, I'm not going to spend a life on opioids. He didn't want to do it. I don't even know if he tried it. Probably, maybe he did, maybe he did. But he tried all kinds of things and said, look, all right, making the decision, it's not a life worth living, and it's been fun, but goodbye. Yeah.
And I get that's part of the work that I do is I make videos of chronic pain, and I get probably 100 of them, 100 to 300 of people that are planning their suicides, and it's this work has become very, very important to me as a result.
Yeah, well, fortunately, the chronic pain I have has been very, very mild, and I don't even take anything for it. But I can understand. It's annoying, and I can understand people. I mean, it's worse than annoying. I mean, it's.
Well, I think that's another thing. We have this false perception. A lot of people, of course, if you haven't been in chronic pain, this idea that you get used to it, this idea that it becomes more manageable because it's become a baseline. And I think a lot of it sometimes is narrative as well.
I don't know that you get used to it as much as that, as you said, you come to expect it.
Right. But that's one of the most dangerous things. We hear people discuss some of these things sometimes and say, well, eventually they become accustomed to it. No, we may know that every morning we're going to wake up in that pain.
Right.
But it doesn't mean we develop a tolerance, or so I should say.
Yeah. Well, that's what some of these therapies are supposed to do, to harden people against it. I've always thought that's, well, good luck to people who it works for.
Right, I agree.
But I don't know. I find that real, like the mindfulness therapies. I had a lot of experience with that before it became a fad. But
thanks for coming. That's some sweet beer.
Are you have standardized patients? We have doctors come in, and students have to.
they had, those would come in.
How much
They'd have
does it
standardized
pick up?
patients.
I have to say, if you can believe it, these do a lot better. They don't pick up even remotely what they should.
I don't know.
That picks up pretty well.
Because when I was involved with any of that, it was before the high tech was really a thing at all. In the what was the anatomy lab, I think they had pretty much everything in there.
Okay, so check the anatomy lab for all this camera stuff.
Yeah, they had plenty of things in there. Yeah, plenty of camera stuff, plenty of audiovisual things that they use. So I mean, not only were they peeling the cadavers, they also had the technology to do it electronically.
The cadavers that are as a prerequisite before you get to nursing. You've done that, so we'd never tear down that anatomy lab. It's too fabulous. But so the people need it before they get to the nursing school. So I have to figure out how to bring those people in. But you're saying maybe that would be where there's already something in place for cameras.
Right. You should talk to the guy who was in charge of all
They are really expensive, but
of all that equipment on campus.
Say it was a few years.
So I'm
trying to think of his name.
That's okay. I'm going this Friday for a tour, so I'm just trying to, get any kind of lay of the land so that when I go Friday, I'll have good questions.
Right. So in the clinics, I don't know. When I was thinking of the what they used to call the OSCE exams.
Yeah.
So.
They did those in the patient clinic?
I don't know if they still do. Again, I stopped working on those many years ago.
Okay.
And I think at one point they were recording, the students. They go from station to station.
Exactly.
Now there were many stations in some of the exams. In some of the exams, they were just, let's say, four patients.
Okay.
So you'd have 4 stations, and you'd have to go through the whole, history.
Different variation on that. Not different. Okay.
Right. Okay.
So anyway, the thing is,
Yeah.
so the clinics and certainly there's two big buildings.
Okay. So I'll look at that specifically. And so you do have a faculty office over there? That's similar to this kind of.
I had.
Sorry.
I moved on in summer. I had an office over in the administration. I was there for a long time. The only administration, the remote presidential suite.
Yeah, okay.
We're on one side.
Okay.
And then all the way to the
I do agree that you
east side of the building. That would be all.
Hi, Rose. Hi, nice to meet you in person. Yeah.
We went to school work, used to be lots of faculty and administration. That was it became very early. That was all administration.
All right, that's very helpful.
Anything else you need?
Yeah, all right.
Okay. Take care. And good luck to you.
Thank you. Well, it's very nice to talk to you. Thank you for the time.
There was one thing I wanted to tell you, this was very interesting. So somebody I knew was on pain chronic had some surgery
The concern I have based on
survived that.
the not so great evidence and lots of
And
different opinions.
still had pain. Eventually was on a pain patch. And,
Rather than
all the pressure and
now we know even if people were now there will be more clarity.
And
Now that these
so the patch would
conditions
be
are
once
and there will be more processes going to be that don't allow it versus
No, this was.
believe that the right individual is deeper to the life and it's both those individuals. Like, so I worry that if we
I think it was
open
two
that
individuals.
opportunity for coverage is not.
Eventually,
And I know that's.
she decided.
It's hard to articulate that.
You know, it was,
That was my
her
concern.
doctor was retiring, she was having to change to someone else. I mean, it's getting kind of silly. It's, all the extra monitoring and it's just coming out of pocket. It works. You want to change it. And finally, she just said, screw it. I am going to do something.
Like if I'm not going to cut, or I'm not, or.
And eventually, she did.
Saying we're not.
But I think in the end, she
Or now we're going to
paying for it.
that make sure. it's not
The
happening.
pain was really just with.
That would be detrimental.
I just sent it to Jean.
Except that.
Or because, that's the difficulty, I'm taking this for pain, and oh, my medicine is running down. Oh my God, it hurts again.
I think that overall the.
Where's that pain coming from?
I mean, the
Is it from
work
the
we do is to make people healthy and
the source of the pain? Is it from the radiation?
That's where right. And I shared it with my staff. Because the same question was asked. That's my, I want to offer the best deal. None of us need to think that they may have been given. My job is to make the papers originally work. Knowing that the owners of that paper. I know you guys can speak separately, I'm sharing my opinion. So. But I hear you.
Probably the rare person.
Right, and that's
Very
Right, yeah, my point was only that,
Yeah.
what I don't think is very clear is
I mean, I think she was
research.
trying to ask.
How much of this pain is caused by
Of course, right, and I would love to know.
I understand that. I would love to hear what happens.
She was concerned that it's
Right.
It's probably had it.
I was on a patch for a period of time, so it's so hot. High, so high.
Like this here.
So we're
So we're even some in terms of your email that's in response to my email this morning. I understand. I have concerns with this. And the message response to
Well, you need it.
I know this is
the extra space, patch, not the medicine, the patch.
Right, exactly. So, so I went back to another method in there.
The fiber reinforcement.
Right, exactly. I needed to figure out, fat or something. Absolutely. It looks like. That would be my concern. So I just wanted you to know that.
Right. So how can we individualize it, but have it done in a circumscribed?
Right. I think it goes forward. Oh, no, I guess what I was saying is we don't have to agree on the early initiative. We listen probably here, we listen, give people that functional information. I think we're able to get more people in this house. So, that's what I'm worried about.
One of the solutions,
That's what I,
unfortunately,
that's what I,
yeah,
I just wanted to make sure.
it's very special types of documentation.
It's just a caution.
Can you show the decentralized?
I am not trying to.
Not.
I know. So I'm not trying to come out. I'm telling you, I told Ariel in there, but I want to make sure.
And then,
the record
and
demonstrate
you get the other problems that requires more documentation or more staff, higher costs.
And I also think part of the. Of course.
Anyway, let me say goodbye to our fearless leader, and then my wife is waiting for me somewhere about an hour away. Okay.
Thank you.
Good
It was
luck.
lovely to speak with you.
Ariel, just wanted to say thanks so much for your
I'm
leadership.
sorry about your name again. I will double check all the minutes.
The problem with that is, people see that, and then they write down my
no.
email address,
Anyway,
and
I'll go check it. Maybe
it keeps bouncing back.
Maybe I would.
Which way is one asked? Oh, that's the problem.
Yeah. Well, and I'm always a Smith and not a Smith, so I totally get it. Or like, I'll say with an S, S-M-A-T-H-S. Thank you, Ariel. Yeah, thank you. Bye, Vincent. Bye-bye.
Good day.
All right, ease on down the road.
No, just trying to get my notes in some order. Thank you so much. Where the bus shows up at 3. Do you need help?
So you got your plate? Yes, sir.
Yeah. So I'll put that one